The essential principles of airway management outside the operating room. This is essentially about the practical conduct of manual ventilation in an emergency situation anywhere in the hospital outside of the operating room. Upon arrival, first, confirm that the patient is unresponsive. When you are sure that the patient has become unresponsive, then you must check, is this patient breathing? If they are not breathing, is the patient's airway closed, or is the patient apneic? Now, here are some interventions for management of this situation. If the airway is closed, we're going to open it. If the patient is apneic, you will need to take over their breathing. And if the cardiovascular system has become unstable, you will correct it. But that is for consideration in another presentation. If the patient is not breathing, we have to recognize that airway closure is commoner than apnea, so our first maneuver will be to attempt to open the airway. The interventions that we perform in a situation like this are manual control of the airway and the provision of manual ventilation. We will, of course, monitor and treat any cardiovascular system abnormalities that may occur, but for the purposes of this presentation, we are focusing on the airway. Our first intervention is manual control of the airway. This implies opening the airway by creating a corridor through which we can ventilate. Management in this situation hinges on detection of expired gases at the mouth and nose. If you can detect expired gases at the mouth and nose, then give the patient supplemental oxygen and continue to monitor their status. If there are no expired gases at the mouth and nose, then the patient either has an obstructed airway or they are apneic. When people lose consciousness, the airway obstructs before the development of apnea. So let us first attempt to open the airway. The manual interventions to open the airway are three very basic airway interventions. We call these the three basic airway maneuvers. First, perform the chin lift. Now, can you detect expired gases at the mouth and nose? If you can, that's great, and just apply supplemental oxygen and monitor the patient. But if you cannot detect expired gases at the mouth and nose, then you move on to the second maneuver, which is head extension. Assuming that this does not work, then you must move on to the third maneuver. The third maneuver is the jaw thrust. After each maneuver, you will recheck to see if you can detect expired gases at the mouth and nose. After the skillful application of the first, second and third airway maneuvers, the airway must at this point be open. Recheck to see if you can detect expired gases at the mouth and nose. If you cannot, then the patient must be apneic and you will need to breathe for them. For novices in this situation, you'll proceed as follows. You will need an anesthesia face mask and a manual resuscitator. So initially, you will use both hands to keep the airway open. You may need to insert an oral airway. Once you have the airway open, you delegate an assistant to treat the apnea by squeezing the reservoir bag, but ask the assistant to ensure that the manual resuscitator is connected to a source of oxygen. In this situation, mask ventilation for more experienced providers is as follows. You will maintain a pneumatic seal around the face mask with the index finger and thumb of your left hand. You will hold the airway open with the ring and little finger of your left hand, and the right hand will treat the apnea by squeezing the reservoir bag. Remember, People die from failure to ventilate. Very rarely do they die from failure to intubate. Never attempt intubation on a hypoxic patient unless skillful bag valve mask ventilation has failed. Why should we intubate? To answer this question, we have to have a sense of the advantages of endotracheal intubation and the disadvantages of endotracheal intubation. The advantages of endotracheal intubation are primarily the avoidance of gastric reflux and pulmonary aspiration in an emergency patient whose stomach is probably full of food and gastric acid. The disadvantages of endotracheal intubation is that a misplaced tube can lead to death by asphyxiation from esophageal intubation. Why should this occur? Well, the limitations of bag valve mask ventilation are that there will be a degree of gastric insufflation, and the longer you ventilate, the more of each tidal volume will go into the stomach. Most gas goes into the lungs during manual ventilation, but some gas inevitably goes into the stomach. After multiple ventilations, the pressure in the stomach will eventually build up, and eventually, as the stomach fills with gas, something has got to give, and the high pressure in the stomach may cause reflux and aspiration. The rationale for intubation in this situation: if a patient needs manual positive pressure ventilation, a normal tidal volume administered by face mask during ventilation should be approximately 500 mL, but this of course will be approximate. If just 10% of this, say 50 mL, enters the stomach with each breath, in 10 breaths you have 500 mL of gas sitting in the stomach. After 5 minutes of ventilation, 2.5 liters is in the stomach, and the stomach will be horribly distended. If the smooth muscle of the stomach experiences excessive stretch, eventually there will be a reflex contraction, giving rise to a big belch, and this drives a mixture of gas and stomach acid up the esophagus into the pharynx. And on the next manual positive pressure ventilation that you apply to the patient's airway, this will spray this very damaging mixture of food and acid from the pharynx into the patient's trachea and lungs. This must be avoided at all costs, and hence, once you have corrected the hypoxemia by bag valve mask ventilation, it is reasonable to then proceed to an attempt at endotracheal intubation if you feel it is safe to do so. As we ventilate, the possibility and the probability of gastric insufflation, gastric acid reflux, and pulmonary aspiration increases. So, as soon as the patient has been treated for their hypoxemia and they are pink, it is time to attempt endotracheal intubation to protect the patient's lungs from aspiration of gastric acid. Thank you for listening to this short presentation. The end.